you referred to them as your little fledglings. You know, they have to go off into the world, and it's nice when there's a wonderful transition program to enable them to do that, and somebody as caring as you that is looking after them. So thank you, and thank you for being here today. Our final speaker of the day is next, and he will give us many reasons to be hopeful for our loved ones. Dr. Dennis Nielson is director of the Pediatric Cystic Fibrosis Center at UC San Francisco Benioff Children's Hospital. He is also a health sciences clinical professor in the Department of Pediatrics at UCSF. In his decades of recognized CF research, Dr. Nielson has increased understanding of cystic fibrosis and explored new therapies. Please help me welcome Dr. Dennis Nielson.
Use this?
I hope so.
Okay, you advance, and then you have to pace it.
Okay.
It's all yours.
All right.
Thanks.
Well, thank you very much. It's a pleasure to be here. I know it's a long day, and I was trying to figure out earlier, am I the caboose in a long train, or am I Buster Posey batting cleanup? So, you know. Hopefully the latter. All right, so today I'd like to focus on some of the exciting changes that are coming in the near future. So there's the far distant future, which is, I suppose we still have hopes that someday we'll have gene therapy and it will work and it won't have any side effects and will actually cure CF. But we have some other really great things in the near future that I think we can all be very excited about. And I'll share a little bit of experience with you that we've had in a study that we've done at UCSF. Okay, so I can probably skip through a lot of this real fast because everybody here knows this, and it's been reviewed a little bit today, but you know, this is our channel, and we have a gate here, and chloride is moving out of the cell, and along with chloride and sodium, water moves, and this is a very important mechanism for controlling the degree of hydration of airway secretions on the surface of the airway. And again, this has been mentioned, decreased secretion of fluid from submucosal glands is an important part of this. We also have unopposed absorption of airway surface liquid that's driven through the sodium channel, so it just keeps getting sucked in and there's nothing coming out, so the balance between the secretion and absorption is just thrown off in this disorder. It's been done several times now, a number of methods showing that the airway surface liquid lining the airways of the lung is decreased in CF, and that has a very important impact on the mucociliary transport that you've heard a little bit about, and also bicarbonate, which is something of actually great interest because for a long time we've known that the secretions in the CF airway are more acidic, but nobody knew whether there was any physiologic or clinical consequence of that. And in the last couple of years we've had some nice data come out that suggests that this hyperacidic airway surface liquid leads to defective bacterial killing. So those intrinsic antimicrobials that were mentioned before are pH sensitive. They're sensitive to the level of acid, and if you throw that off a bit, they don't work as well. And so that may turn out to be a very important mechanism and maybe an important piece of the puzzle of CF that now has come into a little bit of focus. So you all know this is a multi-system disease, and it affects so many organs in your body. It can adversely affect you, but of course the most dangerous thing is what happens in the lungs. So I was asked to talk about the pipeline, and that's what we're going to focus on, but we're going to start in a little different order than if you go to cff.org. I'm going to reverse things or change things around a little bit. And the first thing I'm going to talk about are what I refer to as classic downstream treatments. So, things like optimizing nutrition, restoring airway surface liquid volume, clearing the mucus out, decreasing inflammation, fighting infection. And the CF Foundation is very much involved in sponsoring projects related to all of these areas. So we're certainly making progress. And if we start out with the nutritional issue, and you look at what they've done over the years, the Aqua Adex, a lot of you use at home. You know that they were an important part of this. There are some enzyme products like protamase. And then this thing, which is really kind of very interesting, which is should be going into phase 3 at some time. This is actually a bacterial lipase. So it's a lipase that comes from bacteria, and it's resistant to the adverse effects of acids. So one of the reasons you have those little, you have the gelatin capsule, and inside are the little beads, and the little beads have this pH-sensitive coating to try to keep them from being released too often or too soon. And then we give everybody acid inhibitors and so on. This gets around a lot of that because this particular type of enzyme isn't sensitive to the acid, and so you could avoid a lot of these complicated things that we're doing, and sometimes it seems like we're chasing our own tail trying to get good effectiveness of the enzyme. So this is in the pipeline, and maybe the most interesting thing that will come up soon in this area. Restoring airway surface liquid, hypertonic saline is that's a great story. Everybody likes to talk about the Australian surfers and so on, and I think a lot of us were a bit surprised in the big multi-center trials that showed that this simple therapy actually worked, and it's it's all based in physics. There isn't any medication there. It's just if you put something really salty in the airway, it will suck out fluid by virtue of a thing called osmotic pressure, and it just pulls it right out within a few minutes. So it goes in as 7% saline, and in 5 minutes it's 0.9%, and you've got about 8 times as much water in the airway. It happens quickly, and it doesn't care what mutation you have, and it doesn't care whether there are any bacteria there, so it really works quite well. The biggest problem, of course, is the taste is very salty, although our kids seem to tolerate it pretty well. I've personally tried 3% saline, and that was pretty salty. Made me cough. And it brought up stuff I didn't know was there. It was amazing. Bronchitol, this is an interesting product. This is actually a non-digestible sugar that does the same thing. It creates an osmotic pressure gradient, and it pulls water out, and it tastes sweet. And it doesn't, other than that, it just kind of sits there. So this has been in trials and could come to patients sometime soon. And then there's this product right here, which is very interesting. Most of you probably haven't, although I know that Jeff and Rick have seen this, but the old amiloride trials, one of the things that was thought about early on by the group in North Carolina was that if you could block the absorption of sodium, then that could at least partially compensate for the chloride channel problem. And it's a very sound theoretical idea. And at first there was a paper that suggested that there was a small impact, and subsequent work seemed to show that the big problem was the drug just didn't stay around very long, so it couldn't really do its job. So this is an ENaC inhibitor. The sodium ENaC is the exterior sodium channel on the epithelial cells, and it apparently sticks around long enough to make that happen. And so now we're into clinical trials, and we'll see here in the next couple of years how useful this might be. Pulmozyme, everybody knows about mucus alteration with pulmozyme and how the CF Foundation helped to get that product to market. And we know that it's one of those, I call it an incremental therapy. It helps a little bit. Its benefit disappears pretty quickly. It costs way too much money for the clinical impact, probably. But all of those little things added together account for the tremendous improvement in survival that we've seen in CF. So a little pulmozyme, a little hypertonic saline, a little inhaled antibiotic, and before you know it, the kids are doing better. Ibuprofen, you've heard about that, and it's probably the most effective therapy that very few people do. Most centers have stayed away from it because of adverse side effects of this drug, and people are still looking for alternatives that may not have as much toxicity that might do the same thing. And then alpha-1 antitrypsin, we're still waiting to see whether there's something there that will help in CF. Okay, inhaled tobramycin, azithromycin, Caistin, TIP, the inhaled powder, have all come into the market, driven in large part by the CF Foundation, and they've all proven themselves to be very useful. Inhaled levofloxacin, we may see that soon. I mean, I have sort of my personal biases about some of these things. I'd rather that we inhale drugs that I don't want to use in an IV, which is one of the reasons I like Caistin very much, because astrianam is a terrible IV antibiotic for Pseudomonas, but as an inhaled antibiotic, it seems to work as well as tobramycin. And so I think, in my mind, that's an advantage. I can use all the Caistin I want, and when my patient gets sick and I put him in the hospital, I can still do IV tobramycin and hopefully get a better benefit. But that's a personal bias, and it's not shared by a lot of people, I don't think. But we do a lot of inhaled tobramycin in our place as well. Arikayce, so amikacin is another drug. It's in the same family as tobramycin, and this is another product that would be inhaled, and so it would be an alternative to inhaled tobramycin. And this is moving along in the trials, and we'll see how it comes out. And then Arovank, this is a potentially, I think, very important product because it addresses a question that we're all struggling with right now, and that's the MRSA, the resistant Staph aureus, that with antibiotics we can't eradicate it. We seem to be able to control it most of the time, but it's become an increasing problem in the CF community, and now we have data that suggests that having MRSA actually accelerates the damage a bit in the lungs. And so having a product like this may turn out to be very important. And so we're going to see that here in the near future. Okay, so then let's move away from the downstream things and talk about getting at the root of the problem instead of nibbling at the edges, although edge nibbling has worked for a long time for us, but let's try to get the big hit now. So we know that CF mutations break down into various classes. Some people will use 5 classes, some people use 6. I like 6 because 5 and 6 are just a little different. But basically what we're talking about is we have these chloride channels in a normal membrane. There's a normal number and they work properly. And basically you have a problem of either quantity or function. So the quantity problem is like the class 1 and 2 mutations. So class 1, if you don't remember, is those mutations where you just don't get any translation of the DNA. So nothing happens, you never get a protein. The class 2 mutations, you get translation, but then because the protein is misfolded, the quality control devices inside the cell says, oh, this is a defective protein, I'm not letting it through, it stops it, breaks it down and sends it back to be recycled. And so it's like you never had it because it never makes it to the cell membrane. So you end up with little or no CFTR protein in the cell membrane. And then you have the class 5 and 6, you have some CFTR, but what is happening here is that class 5 is decreased production, so you have a decreased amount of the channel around, or the class 6 is the half-life, the amount of time that the protein stays in the membrane is too short. So it goes in, but then it disappears rapidly. So the net result is, again, there's some there, but not enough. And these particular kinds of mutations generally are milder than the class 1 and 2, just because there's more functional protein around. Then you have the gating defect, the class 3. So the most common one, G551D, and then there are 9 others. And 9 out of 10 now are approved for use with ivacaftor. But these all are the gating defects. So you make the protein, gets to the cell membrane. Its conductance may be relatively normal, but the gate doesn't open. And if the gate doesn't open, then it might as well not be there. And so that was turned out to be a problem that was relatively easily attacked by the search for useful pharmaceuticals. And then the conductance defects, so these are the class 4. So the gate opens, the protein's there, the gate opens, but then there's some problem with the size of the channel or the charges inside the channel that make it more difficult for the chloride to get through. So you have a decreased amount of chloride getting through, even though the quantity and the surface may be normal, and it may open okay, but again, you have just decreased chloride moving through there. So, if you're going to attack something like this, it's always good to have a plan. So my version of the master plan is, you want to understand what's going on. And so over the years, we've done things like identify and sequence the gene, understand how the protein is processed, understand how the channel functions, the half-life, and then we try to figure out some way to compensate for the defective function. And so then we target the basic defects. So, gene therapy, that was the great hope in 1989. I mean, you guys were probably sitting there, and we were in Florida, and at the Saturday night dinner, and Dr. Bell stands up and he says, within 3 years, gene therapy will be routine in cystic fibrosis. Okay, that was 1989. All the research grants started going to the gene jockeys, right? Couldn't get money to do anything else. But here we are, in 2016, and we're still a long way from gene therapy. Maybe another 20, 30, 50 years, who knows? Who knows how long it will take for us to become smart enough to make that work. But someday, and it'll be great, I'm sure. Okay, so then you can do other things like, there are a lot of the mutations, those that usually they end in X, like G542X, which is the second most common CF mutation. What happens there is you get a stop sign as the gene is being read, and so you end up with a short protein that doesn't have any function or may have very little function. Correctors and potentiators. So this was an idea that came about a number of years ago, and this correctors refers to what we do like with G551D. The channel is there, and you do something to make it open up. You turn it on, and you make it work better. So that's a corrector. Or excuse me, that's not a corrector, that's a potentiator, sorry. The correctors are the drugs that actually chaperone the protein through the cell, help it get inserted into the membrane, and increase the amount of CFTR protein there. So the correctors increase the amount that's present, the potentiators improve the function, and now we're beginning to look at some things like that class where it turns over too quickly, or even in the defects where there's a little bit of protein that gets through there. If you could stabilize the CF protein and make it stay in the membrane longer, that would still be a good thing. So now people are beginning to look for molecules that might actually stabilize the protein within the membrane and just make it hang out there longer so that you can get more use from it. And then the things like, do something about ENaC, find some alternative chloride channel. So far, this hasn't been terribly successful. We'll see about the ENaC inhibitor, but this right here, the potentiator, that's been the first really great success in this search for something that gets closer to the root of the problem. Now, then we face another problem which has been alluded to earlier, and that is, how do you figure out how well this thing is working? Because with all of our therapies like Hypercell, Toby, Pulmozyme, and so on, you know, we've made enough progress that our kids are healthy, they live long. You know, it's a different world than it was 30 years ago in the CF clinic. It's completely different, thank goodness. But it also makes it harder to figure out when something is working because it turns out that something like, you know, percent predicted FEV1, forced expiratory volume 1 second, which was, somebody got that question by cheating actually, but it's okay. I knew the answer, but it turns out that FEV1, even though it's, you know, it's been sort of old reliable for us, and a lot of us are pulmonologists and we like to measure lung function, turns out it's just not sensitive enough and it doesn't change fast enough. And I can show you CT scans from a number of my patients. It seems like they're mostly older teenage girls. I don't know why that is, but they have big holes in their lungs and their spirometry may be completely normal. And there's damage, there's serious damage that's been done, and yet that number fails to identify the problem. Whoops, what did I do here? Push the button, okay. So that's an issue. CT scans are good, but there's radiation and there's concern about lifetime dosing. It's at this point still probably the most effective way, the most sensitive way to look for early damage in CF. Then we have another problem, and that is that, you know, the classic way that we've tested drugs it's already, we've done about all we can do. You know, you've got Delta F508, where you have close to 90% of 30,000 people in the US have at least one copy of that mutation. But we've got, you know, a couple thousand other mutations, and at least 1,000 of those cause serious problems. And some of them are very rare. How do you decide, you know, how do you figure, provide something for them? Now, you know, if we get a really good drug for 508, that'll be great. It'll be a huge jump, but there's still going to be people like, you know, the baby I admitted to the hospital last week who has Q98R and is homozygous for it. And this baby has bad disease. So what am I going to do for that baby if all I can give are FDA approved, or a drug to for FDA approved mutations, and all we can study is 508, 551D is, you know, it's 4%, a little over 4%, and all the gating mutations together are 5 or a little over 5% of CF mutations. That's a small thing, and then you have these really odd things, and what are you going to do with them? So as of a couple of years ago, the foundation started to talk about N-of-1 trials, which I'll talk about some more. So this is a way where you give somebody a drug, regardless of their mutation, and you need to have some sensitive, rapidly changing outcome that will reflect impact of a therapy. The problem is that sensitive, rapidly responding outcome measures were very limited in that area. FEV1 isn't good enough. Waiting to see how often you get sick, you know, the exacerbation rate is something we've used over the last few years, but, you know, we're at a point where that's not good enough and requires large numbers of patients. And we really don't have a lot of other things, and you know, the old sweat test has been beaten up in the literature lately, and Dr. Wine and some others, Dr. Quinton down in Southern California, are trying to figure out new ways of doing sweat tests that make them more sensitive. And it is a functional test, and we know from the ivacaftor studies in G551D patients that sweat chloride, where there's a huge change with the gating mutations, it starts to occur within a few days. You see, you know, they did, in this early studies, they were doing sweat tests very frequently, and, you know, by 2-3 days into it, you were most of the way to where the change was going to occur. Long-term clinical outcomes, you know, you're going to have to look at those no matter what, and those are going to continue to be important. but we're going to argue about which outcomes to look at. So here are numbers, let's see, I forget what, is this 10 or 11 or whatever? So 508, high percentage of patients carry at least one copy, and you can see how fast it drops off. G551D, a little over 4%. This, which is one of those mutations that gives you the premature stop sign, 4.6%. R117H, which as of December you all know is approved for the drug. We'll talk a little bit more about how useful ivacaftor is in that particular mutation. You know, not quite 3%, and so on. And then I put in number 22 down here because I'm going to talk a little bit about some results we have with that one. Okay, so here's the pipeline that relates to trying to get at this root. So here's Kalydeco going to patients. Adalurin, this is an interesting molecule that failed in the phase 3 trials, but now it's being looked at again because it has an interaction with tobramycin that may have inhibited its benefit. So it may have some usefulness. Lumacaftor, ivacaftor, everybody I think knows about this. This is we have another kind of interesting name for a drug, Aricambi or Arcambi. Okay, so let's see. We have Caiston, a Caribbean island. We have Kalydeco. It sounds like it's from New Orleans, and there's an accordion somewhere in there.
Dennis, you forgot. In California, we call it Kalydeco because it was nice about the name.
Oh, is that what it is? Okay. All right, so we have a new thing to think about now. But Aricambi, I don't know, is that, it must be it's a German camper, right? Like a Vanagon? You remember the Vanagon? There we go. All right. I don't know what, they pay millions of dollars for these things, don't they? How do I get some of that money? Wow. Okay, so there's lumacaftor, ivacaftor that we hope within the next few months will actually come into the market. There are reasons to be excited about it, and there are reasons to be more hopeful that this combination that's coming right after it, that's now going into phase 3, 661 plus ivacaftor, may turn out to be a better combination. And I can tell you that at least in isolated cells, 661 works much better than 809 in terms of doing the correction, moving that misfolded protein through the cell and getting into the cell membrane. So I'm hopeful that as long as the toxicity isn't worse, that might actually be a significantly better combination, but it probably won't be the final answer either. This QR010 is an interesting drug. This is a drug that's being looked at that actually repairs the RNA. So if you remember how proteins are made, you have DNA that, code, that's the gene, okay? And the DNA gets translated into RNA, and then the RNA gets translated into protein. So this is a drug that's attempting to get actually closer to the root problem where you're not correcting the DNA, but you're correcting the RNA. And at this point, I don't know, I don't have any idea how effective this is going to be, but it's going to be very interesting to watch this and to see how useful it looks like it might be. This particular, and I don't even know how to pronounce that, it looks like Rio de Janeiro Ciguat or something. Rio Ciguat. What, do you know? What are they?
I'm just guessing it's Rio Ciguat.
Rio Ciguat. That's as good as any. All right, I'll take that. Anyway, this is a Bayer drug that stimulates CFTR channel expression. And again, it's pretty early on to know how useful it's going to be. QBW, which is another potentiator. So this is an ivacaftor-like drug, and it's a Novartis drug. So last year I heard that Novartis was in the game, and this year this is the game. So they're looking for something to potentially replace ivacaftor. And that could turn out to be important because it turns out that ivacaftor which we've started out thinking is just a completely wonderful drug with very few side effects. Turns out that it does have a dark side, like most things in medicine. And there were a couple of papers, one from UCSF and one from North Carolina, showing that ivacaftor, in addition to improving gating tremendously in many mutations, the dark side of it is that it decreases the amount of mature protein that gets through the cell. So it gives you less protein, less CF protein to work with. And the amount of correction that you get in the chloride transport across this cell membrane in the lung or wherever is dependent on how many channels are there and how much of the time they're open, and then their conductivity, of course, and how long they stay in the membrane. And so all of those factors add up to how much correction you get. So you're forcing the channel open more, and it turns out that ivacaftor works on just about every mutation that has been tested on. For example, normal CF protein, the open time, the amount of time the channel spends open, is double on exposure to ivacaftor. And delta F508 protein, if you use a few tricks to get some into the cell membrane, quadruples the open time, which is why this drug went into trials with something like lumacaftor or VX661, is because it'll actually activate those channels if you can make them appear in the cell membrane. Let's see. This N9115, Nivalis, I don't know that company, but it increases S-nitrosoglutathione. Glutathione it's a scavenger. It scavenges certain kinds of destructive molecules in cells. And so in a way, it's kind of an anti-inflammatory. Don't know how useful that'll be. It'll have some utility. Is it going to be great? I don't know. If I were going to bet my money, I would still bet it up here on things that correct and potentiate the CF protein. Okay, so Kalydeco, these are little channels. The gates are closed. That's the problem. You put in the ivacaftor, it opens the channels, and the chloride ions, these little dots then can start to flow through. And so what I just said is illustrated here. You have total chloride transport that is a function of channel gating, how much time it spends open, the conductance of the channel, how easily the chloride moves through the channel, and then the number of channels that are in the cell membrane. And so ivacaftor affects this function. It doesn't affect, well, it adversely affects this part right here. Okay, so by doing that, then you normalize chloride movement. And the attempt then is this is a plot of sweat chloride versus activity of the CF channel, and it's kind of an approximation of what really happens. But you have somebody with a sweat chloride of 100, and they have near zero CFTR activity, so there isn't much happening. But if you have a milder mutation like an R117H, where there is protein present, your sweat chloride tends to be lower, and you start to see some CF channel activity. And then down here you have these really mild mutations that maybe cause male infertility but don't do much else to people. And you have a sweat chloride that's maybe in the upper limits of the normal range, and you have pretty good activity, and those people do fine in terms of their lungs and so on. You have carriers where 50% of the channels work, and they're down here pretty close to normal. They tend to have, on average, sweat chlorides that are a little bit higher, but they have pretty good activity. So that's kind of the relation between those two things then, the sweat chloride and the CF channel activity. And ivacaftor and the G551D studies, to just quickly go through some of the data, if you look at chloride transport as a percent of normal, And you have no, and these are 508 or cells or people with 508 homozygote state. You have very little transport of chloride without the ivacaftor, so less than 5% of normal. And with the ivacaftor, then you get this change in the sweat, in the transport that goes up close to half normal. And your change in sweat chloride then in the G551D trials between no ivacaftor, the placebo, and the group that got the ivacaftor, in the studies it was 45 to 50 millimolar decrease in the sweat chloride, so that many of the participants in those studies actually had normal sweat chlorides, some of them down into the 20s. And when you looked at those patients as a group, you saw an improvement in the FEV1. The average was somewhere around 10%, which was sort of, I'll show you why I think that in some ways that's sort of the problem of regression to the mean, because this particular drug in people who have these class 3 gating mutations is a really powerful therapy. So if you go back and you look at the studies, you see the absolute change in predicted FEV1. It went up and it stayed up, and this is, a year-long study. You can see that it has sustained benefit. The sweat chloride actually went down and stayed down. This is the CFQR test. They saw tremendous weight gain in the patients. So these patients were gaining, 10 pounds without trying. And when you looked at the time to first exacerbation, there was a huge difference between the placebo group and the group that actually got the drug. So, okay, those are great things, and sometimes it's useful to just sort of, okay, so what does it do for my patients? So here are 4 of my patients who have gating mutations. 3 of the 4 have G551D. This young lady has a mutation called S549N, and we have just decided we wanted to know what their sweat chloride was like. One of these is a young man who's now been on Kalydeco for 5 years. So we got his data from the study, and the others we've just done on our own. But you can see these are huge drops in all 4 of these. Now the only one who's kind of on the borderline of normal is this one right here. But the other 3, they're in the 20s, so a huge drop. And they all had pretty classic sweat tests to begin with. And what I can tell you is they've all done tremendously well. None of these 4 have been in the hospital. None of them has required IV antibiotics. They all feel great. And the young lady at the top, she was the sickest of these patients. And she's the one with the S549N. We wrote her up as a case report that was published in Chest a while back. And as a 12-year-old, she had a continuous cough. She coughed up just tons of purulent sputum. She had to stop every 5 minutes to rest when she was out at the mall with her mom. She couldn't participate in PE. She couldn't do the dance class that she wanted to do. And she spent 116 days in the hospital in the 2 years prior to starting the drug. And she hadn't been home for Christmas for 5 years because she was always in the hospital. So we got her funded before these had FDA approval. We started her on the drug, and this is what we saw. So her cough stopped within 3 to 4 weeks, completely disappeared. Her sputum production disappeared within 4 weeks. So she couldn't cough up sputum anymore. In fact, we ended up doing bronchoscopy because we couldn't sample anything, and we were wondering, did we eliminate the MRSA and the stenotrophomonas that she had? And if she gets sick, what are we going to treat her with? And she had a bronchoscopy that was completely normal. She had no purulent sputum in her airway at all. And before we scoped her, and like most 6 CF patients, she had what I call the river of pus. You look down there with the scope and you see this pus just streaming up from down below. And that's what sicker kids cough up. So FEV1 at the start, 33% are predicted. That's just a few points from the time when you call the transplant team and say, I have this kid I want you to see. And she was, this was a patient and a mom, family that were great. There was just no doubt that they were doing pretty much everything we asked them to do. So she's now been on ivacaftor for a little over 2 years. So she went from 33 to about 50% of predicted within 5 or 6 weeks. By the end of the first year, she was up to 60%. And I had her in clinic a couple of weeks ago. She had 71% of predicted on her FEV1. Her CT scan is still very abnormal in that she still has big holes. But all of the stuff, all of the plugs and that fuzzy looking stuff when you do a CT scan, it's all gone away. It's crystal clear and crisp when you look at the images. The walls of the airways are thin, and in bronchiectasis, the damage you see in CF, the walls look thick because of all the inflammation around them. That's all gone away. She's not had any IV antibiotics since starting. She hasn't been in the hospital. And now she's spent the last 2 Christmases at home. She does dance concerts and stuff, PE, all that junior high school and high school stuff. She just turns 15, 16, so she's on her way to high school. So these kinds of, the kids who are really sick, and you see this kind of thing happen, this really demonstrates the potential power of these kinds of treatments. So, well, when we scoped her 5 weeks out, she still had MRSA and steno. We haven't done that since. I don't know how I would justify that, but she had few organisms, so it looked very clean, but she did grow out a little steno and MRSA. But this year, I don't know. If we looked again, she might not. Yeah?
Have you been able to reduce her treatment burden in any way?
Well, we thought about it, and I think it's probably reduced itself a little bit. I think she's probably not quite as faithful as she used to be because life is good. But, talking to her mother, we talked about cutting back on something that doesn't do very much, like pulmozyme. She doesn't have a lot of pus there anymore, so there may not be any substrate for the pulmozyme to work on. I suggested that. We talked about it, and her mom didn't want to do it. So she's still on everything at this point. So I don't know the answer to that question. All right, so normal CFTR, that's your baseline. If you expose it to ivacaftor, you get about a 50% increase in chloride transport. G551D untreated if you're looking in what's called an Using chamber. At baseline, you get about 1% of normal chloride transport, very low. You add the ivacaftor, you get up to about 55, which obviously has a huge therapeutic impact. S549N, which this little girl had, will go from a very low level, so it has a very severe phenotype, up to essentially a normal amount of transport, at least in cultured cells. So we think that this is why our patient who was the sickest now is probably the healthiest of the bunch. Okay, you recently heard in December about R117H, which is an interesting mutation because if you have R117H with this part of the gene that regulates a splicing step that's called the poly-T tract, if you have 9 Ts with R117H, it's like nothing is wrong. If you have 7 Ts in a row, those are thymidines, you have sort of intermediate risk. And if you have 5 Ts, you've got and you've got a 5 weight on the other one, you've got classic CF. So what did the data look like for R117H? So R117H at baseline, 33% are predicted, and on ivacaftor actually, at least in the cells that are homozygous for this mutation, you do great. In the patients that were in the R117H trial, they saw a change in sweat chloride of a -24 with a very good p-value here. That means there's a chance of 1 in 10,000 that this was an accident. So not very likely. So this was a real change, and you can see the difference between the placebo group and the group that got the ivacaftor. And so that was sustained throughout this time. And their lung function, placebo, ivacaftor, you can see they saw this increase that was 3-4% improvement in the FEV1. And when they came off, as part of the study, they came off at the end of 24 weeks. They dropped down very quickly, and then they did an open label, so everybody got the drug, and then everybody went up. So that's pretty remarkable that, shows a nice response, but the change in sweat chloride was only half of what it was in the G551D trial, so much smaller. And the improvement in FEV1, although this is in a relatively small group of patients, the improvement in lung function was not as good. In terms of weight gain, body mass index, it did go up a little bit, not enough to achieve statistical significance. So, that's what the R117H did, and it was good enough that the FDA said, yeah, we can do this one too. So I have another one for the FDA, and we called our little trial SING. I thought it was dumb. I made it up, and then everybody said, yeah, we like that. I thought we needed something, It stands for short-term trial, short-term ivacaftor and non-gating CF mutations. Okay, so there's an SING, all right? And so we talked about this before. It works on the majority of channels. And there are some patients who have clinical signs of residual function. So we were looking for people who had pancreatic sufficiency, whose sweat chloride was a little bit on the low side, so we're looking like 55 to 85 people with sweat chlorides in that range. And then those few patients who are incredibly healthy, have great lung function in spite of having 2 bad mutations. And so we said, well, we can't go around doing, these tests on everybody, but how could you choose them? And so we thought, well, maybe we could pick them out this way and look for patients who fit this description. And we figured that this might be an indication of residual function and that those patients then might respond to ivacaftor. And so we looked for a response in lung function, sweat chloride, weight gain, and we have nasal cells that we're culturing and we're studying now in these little chambers on the bench looking at the response in a laboratory. All right, so there are 2 mutations. This is that same list. So there's number 22, A455E. And then there's this mutation that's really interesting, 3849 plus 10 kb C for T. That's only 1.5% of all mutations. But it is fairly high up on the frequency list. A455E is number 22 on the list, only 0.5% of mutations. And I'm going to show you, talk about in our little trial what happened with a couple of people. So here, this was actually patient number 1 in our study, 59-year-old CF male, G542X, so a bad mutation, the second most common and severe. So this results in no functional protein. And then this mutation, he was pancreatic sufficient his whole life, but as a 59-year-old, his FEV1 was now 52% of predicted. He was getting a couple of IV courses a year. He felt lousy. He was coughing up sputum all the time. And, his quality of life was not so great. So we put him into our trial, and what happened was he had, so this right here represents the drop in sweat chloride. So this didn't really happen on this time scale. But at baseline, his sweat chloride was in the high 50s on average, varied a little bit. Some people with lower sweat chlorides their sweat chloride values seemed to bounce around a bit, but his average was somewhere around 58. And on the drug, he dropped down into the mid-30s, which is considered a normal sweat chloride. So but in the study, in the 2 weeks, so this is 2 weeks randomized crossover. So 2 weeks on placebo, 2 weeks on drug. We don't know which is which. We measure everything. We couldn't see any change in lung function in that amount of time. We didn't see any change in his weight in 2 weeks. But based on the drop in sweat chloride, his physician successfully argued for the insurance company to pay for the drug. So this is a 9-month experience then. So here, this is his FEV1. So his FEV1 went from the low 50s, and by the end of 9 months is almost up to 60% of predicted. His weight went from, I think it was 68 kilos, and now he's up in the mid-70s, about 75 kilos for his weight. So over a 9-month period of time, even with a relatively small change in sweat chloride, this particular patient, I think, shows clear long-term benefit. But we had to, watch for 9 months. And our little study was privately funded, and, we paid full price for the Kalydeco, which ate up most of our money really fast. So we were stuck with 2-week trials. But anyway, on the drug long-term for clinical reasons, you can see that there is this improvement. And in 9 months, he hasn't had any IV antibiotics. He hasn't been in the hospital. He's producing less sputum, and he feels much better. So there you go. All right. Let's see. I think this one right here, A455E, the 22nd most common CF mutation, 0.5% of mutations. We had 2 ladies in our group with this mutation. One of them had 508 plus this, and the other one had a mutation like this. I don't remember exactly what it was. But if you look in cells, like Dr. Van Goor did some time ago, what you see is with A455E, with acute exposure to ivacaftor, so these are cells, non-human cells, transfected, whoops, keep hitting that button, transfected with 2 copies of this mutation. At baseline, there was 6% of normal CFTR function, and with ivacaftor, it tripled up to 18%. So a very small increase. But, cells aren't people, and people who have this tend to be pancreatic sufficient, so that our criteria. So we put our 2 young ladies on the drug, the 2-week trial. And what happened was a very interesting thing. Their sweat chloride went up by 20 to 30 millimolar, went up. Now their lung function didn't deteriorate. They didn't clinically deteriorate in 2 weeks' time. It's a very short time. But that suggested to us that this is not the drug for them. And I think that we had all sort of assumed that anybody who had residual CFTR function, you put them on this drug, they should get better. But we found, at least with this particular mutation, it appears that the dark side of ivacaftor might be the predominant effect. That you do see in these cells that there's a little improvement in the gating, but this is an acute exposure, and our patients had a 2-week exposure, which is a long enough time to see the impact on the maturation of the protein. So that we think what may have happened, and we're going to use our cells, hopefully, to try to answer this question, it may be that longer exposure to the drug actually decreases the mature protein so much with this mutation that increasing the channel open time and improving things this much doesn't really matter. It's overwhelmed by the other effect. So, there's a cautionary tale here that not everyone should get it. We did have in our study a couple of other patients who had splicing mutations, which are in that group that we think might respond, and we saw no change in sweat chloride. So we had, out of 8, we had 4 where there was a change of 13 to 40 millimolar in their sweat chloride. And one of those, the one that had the biggest change, had 2 severe mutations. And you would have predicted there would be no effect, but he's 6'3" and big and strong. And we saw a 40 millimolar change in his sweat chloride, which surprised me. I didn't think anything would happen. So 4 out of 8 got decreased their sweat chloride, 2 no change, and 2 actually increased. So very small n, I know, but let's see. Okay. So, the target that we're mostly interested in is this one, because that is something 90% of people, close to 90% of CF patients have. which is why this is so interesting and why this is even more interesting, because it may actually be a better combination. But there are some people who think that you really need a triple combination in order to make this work. And then, there are these other things people are thinking about. But here's a little data that I Googled from an internal Vertex document. It was on the internet, right?
It must be true then.
It must be true. So they did an experiment with, these were human bronchial epithelial cells. So these were from patients, and you can see they had 508 G542X, 508, 508, 508 G551D, lumacaftor, ivacaftor, and you can see with 508, nothing, that's the baseline. You add the lumacaftor, there's a little bump. You add the ivacaftor by itself, there's a little bump. You put them both together, there's a little bigger bump, just like in humans. So the cells were behaving. 508, 508, baseline, lumacaftor, ivacaftor, not much of an effect of ivacaftor by itself. Lumacaftor, you get a little bump. You put them together, you get some additive benefit. And then here's G551D, so here's nothing, lumacaftor, a little bump, ivacaftor, a big bump. The two together, up to 80% of normal, of the normal cells.
These are all acute.
These are acute exposures. So we don't know what impact the suppression of mature protein might have on these numbers, but these are all acute exposures. Okay, so here's one where there's a second corrector added, and they didn't say what that was. That must be the secret sauce. So here's 508 G542X, lumacaftor, or nothing here, lumacaftor, little bump, ivacaftor, a little bump, the two together, a bigger bump. Add the second corrector, big bump, up to over 30% of normal in these cultured human cells. And here's 508, 508, same thing, no drug, lumacaftor, which is the corrector, ivacaftor, our friend Kalydeco, the two together, and then add the other corrector and a big bump up to 40% or more of the wild type, the normal cell. So, I don't know what number 2 is, the second corrector, but this is what's coming. So we're probably going to see triple combinations in the next few years go into clinical trials. There will be other drugs. 661 may be a much better drug than lumacaftor. So, if you have a combination like that and it benefits patients who have this mutation, this mutation, this mutation, this is kind of like 508. It might work in this one, we don't know. And this mutation, very interestingly. And, if you put the combinations, I don't know what will happen here. I don't know. So the point of this is that I think in the future we're going to continue to see these new drugs, and we're going to have to think about new ways to test them. And the FDA is going to be really distressed about this, I think, because it's not going to fit into the usual nice package where you have 1,000 people, 500 in each group, and you do your randomized placebo, double-blinded crossover, or double-blinded study. And it's just not going to work because, once we get down beyond number 10, these things keep getting rarer and rarer. All right, there's the master plan. And, some of these things, hard to say, it could be really exciting, but, this is where the money is for the next little while. And I think that we're going to have to start thinking about what I refer to as N-of-1 trials, where a patient serves as their own control. And in order to spread a wider net and allow more people to use these drugs, I think you're going to see more and more of this. And that's it. So what time is it? Oh. Are we on time? Okay, questions? Yeah, DJ.
It's not a question, it's a comment. I just want to say, this is fascinating. And it's for our people. I just have a comment. Your talk was fascinating, and you are my new hero and role model for getting drugs approved for people.
I can tell you one thing about insurance companies. If you have a little data, they fold very quickly. But you got to have the data, and that's going to be the challenge, is that who's going to pay for a month of ivacaftor out of pocket? I mean, that's $24,000.
My question is along the same line. What work is being done to sort of convince the FDA that different outcomes to look at besides FEV1 in patients, especially where, we have all these other treatments that keep them healthier for longer. So the change in sweat chloride, are those secondary endpoints in the trials, or are they primary?
Yeah, so far the sweat chloride change has been a secondary outcome, and they continue to look at FEV1 % predicted change. And there's so many things that affect that. When you look at the data from the G551D study, for example, some of the FEV1s, a lot of them went up, but some of them went down. I mean, that could have been a rhinovirus infection or something that made a kid sick. We know that now that we test for all these viruses, I've had 2 babies in this year, one in the hospital a couple of times, rhinovirus, RSV, parainfluenza, you name it. Any of those respiratory viruses can make a child with CF very, very ill. And those things happen. So when you see the package labeling and it says this drug is associated with exacerbations of CF or it's associated with pneumonia, I mean, that's generally what you're seeing is you're seeing bad luck, the stuff that happens to all of the kids sooner or later. Other questions? Yes.
You mentioned a drug that it was increasing the production of glutathione. Was that in the liver or in the lungs? N9, 11, 15 or something?
Well, this was given systemically, but I think the current belief is that the production is in the lungs. It's local because this is a scavenger. It picks up what are called free oxygen radicals. And these are highly chemically reactive materials that we all have, and we all make these molecules in our lungs that will pick these up to keep them from doing damage. So the glutathione idea has been around for a long time. I kind of doubt that it's going to ever be a major therapy, but it may turn out to be useful. Maybe like homozyme. All right.
I think that leaves us all with a lot of hope.
Definitely Buster Bunny.
Huh?
Definitely Buster.
I tell you, it just can't happen fast enough, right? That's the problem. We need more money. It needs to happen faster, but thank you, Dr. Nielson. I think we're going to leave here today with a lot of hope for our loved ones. So this concludes our first conference for the pediatric CF education portion of what CFRI does. Thank you for coming, and a couple of housekeeping things. Please make sure you have turned in your conference evaluations. Those are really important for us. Mary will take them. Your CFQR and your PHQ-9 questionnaires. If you're not on our email list, please sign up so that we can keep you informed as to what's happening at CFRI and information on breaking research, if we can get Dr. Nielson to, zing us some emails. CF-related events, and I really want to thank our phenomenal experts who shared their day with us, shared their expertise. We've all learned so much, and we really appreciate it, and we could not have done this without the support of Vertex, our primary sponsor. So Holly Devlin, thank you. And also to our exhibitors, activists, Modern Health, Chiesa USA, Cystic Fibrosis Services Incorporated. So it really does take a lot of people to be able to put something like this on, and we appreciate it, and we know that Adriana has spent her day here interpreting, and we will have 500 DVDs in Spanish to the CF clinics. We appreciate everything. And before you go and navigate your road, you have to do one more thing. Make sure you have a blue ticket so you can get out of the parking garage. And if you don't have a blue ticket, because that's your complimentary parking, Siri has the blue tickets. You insert your white ticket, and followed by the blue ticket, and you can begin your journey again along your CF road. So thank you very, very much for being here today.